progress.
Okay. So today we will discuss sickle cell disease. Okay. So before we just start, do anyone know what is sickle cell disease? If someone asks you what is sickle cell disease, what is it? It's a
It's
hemoglobin.
a hereditary
It's a
problem of,
hereditary disease. Okay.
yes.
It's a sort of hemoglobinopathy. This is one thing. This is a hereditary disease. Okay. It may be just a second. If you can mute yourself, please, whoever is joining. Okay. So there is abnormal hemoglobin. Okay. There is abnormal hemoglobin, which is hemoglobin S, and you can say by S for sensitive. Okay. So it is very fragile and it is not able to tolerate the stress. Okay. So whenever there is any stress, it tends to sickle, it tends to clump, and it will result in. Just a second, please. I thought I get put it on charging. Okay. So when there will be clumping, there may be resulting in occlusion. Just a second, actually, I don't know what has happened. There is some problem charging. Just give me a second, please. Okay. So please close your camera. Okay. So when there will be clumping, there may be occlusion. It will be resulting in ischemia. Okay. So this is the basic pathology which is occurring. And the result is actually there are something which are related to the oxygen carrying capacity. I don't know what has happened. Apologies. There is some problem in my, it's not charging or what. Anyways, so there are some problems related to oxygenation. Okay. And there are some problems related to occlusion. Can you see the screen? I'm sorry. See, you should respond. I will repeat
Yes.
again. Hemoglobinopathy, hereditary problem. There is abnormal hemoglobin S. This is sensitive. It does not tolerate the stress. It sickle, it clump. There is occlusion and there is ischemia. Okay. So there is problem related to oxygenation and there is problem related to occlusion. Okay. So there will be infarcts. There will be ischemia. And actually, this is anemia. Okay. Because there is low oxygen carrying capacity. So there is all the compensatory mechanism which occurs in anemia. Okay. So this is what would you need to have a concept before you just start reading this topic. Okay. So let me show you. So actually, when there is like if it is as it is as I told you that this is a hereditary process. So if it is homozygous, so there is both genes are problematic. So the disease, it will be called as disease. Okay. And it will be severe form. Okay. And if it is AS, so it is trait, sickle cell trait, and it is mild. Okay. So this is the basic concept. And then, okay. So there is actually there is, what is the exact substitution? There is substitution of glutamate to valine. Okay. And the only this one substitution will result in like weaker or sensitive or whatever you say. So as I told you, okay. So this 6.5 kp is around, if I'm not wrong, around 60 millimeter of mercury. Okay, 742, around 50, or just convert it by 7.5. Okay. Because kp is the SI unit, and in the British material you will be finding it. Okay. Then we will just see that there will be something which will be exacerbate or precipitate. You can say the word stress. So stress is because of stasis. Like the interpretation will be that tourniquet will be a problem, or any venous stasis will be a problem. Then hypothermia. Hypothermia will be a problem. Okay. So you have to avoid hypothermia. Then dehydration is a problem. If the viscosity is increasing, the result of the sickling will be more, and any infection or acidosis. Okay. So this is the pearl of what you need to know for sickle cell disease. So all the symptoms will be related to like anemia. Okay. And if the patient is receiving repeated blood transfusion, so there will be chances of infection, there will be chances of iron load. So the common things which may be there as a result of treatment. Okay. And the symptoms, actually, this is, you can memorize it by a mnemonic: VASH, vasoclusive, aplastic, sequestrational, splenic sequestrational, and hemolytic. Okay. So you should be knowing that when there is aplastic crisis or vasoclusive crisis or hemolytic crisis or sequestrational crisis, there will be some result. Okay. So hemolysis, there will be associated jaundice as well because of hemolytic anemia. Okay. Whenever there is splenic sequestration, there will be splenomegaly. Okay. Whenever there is anywhere there is occlusion, it may be in pulmonary, it may be in brain, it may be in periphery, it may be resulting in complicated cholelithiasis and all the biliary tract infection, biliary tract problems. Okay. So if you have the concept, I again repeat that if you understand what is this sickle cell disease, it will be easier for you to approach. Okay. So this is the base thing. Then clinical signs, as I told you, that whenever there is anemia, the result is left ventricular hypertrophy, the increased blood volume. There is high output cardiac failure. Okay. So the things will be the same. They have used the word cardiomegaly. Actually, if you don't want to read something special, that what are the changes in cardiovascular system in sickle cell disease, there is nothing special. Anything related to anemia, you can speak out. Okay. And sorry, if anyone wants to speak out anything, you are all welcome. Okay. Any comments, any questions, you are all welcome. Okay. Whenever you are trying to understand this thing, you remember one thing, that there will be problems related to anemia, or there will be problem related to occlusion. So just keep this thing in mind and think in any system, you will find what is the problem. Like, for example, if you think about neuro, there will be ischemia because of occlusion. So it will be resulting in either TIA, CVA, or it may result in cerebral hemorrhage. Okay. So similarly, in hematological, there may be a plastic crisis. So all cell lines will all of you are requested to mute yourself. Okay. Or if anyone wants to ask, just raise the hand. So this respiratory system, there will be dyspnea, cough, hemoptysis, pleuritic pain. All this is because of ischemic symptoms. Okay, and it may be resulting in pulmonary infarcts. There may be severe chest pain. That is pleuritic chest pain. Okay, and this head and neck, frontal bossing, prominent maxilla. Uh, can someone tell what is why this maxilla and frontal bossing occurs? And there is hypertelorism. I don't know there is tarring of the skin. What may be the reason for these things? Yes, anyone can tell, please. This is because of repeated blood transfusions. Okay.
Iron overload.
Yes, iron overload. Okay. So remember one thing, this is the basic theory to understand any topic, that there will be some things related to the basic pathology. There will be something related to the complications, and there will be something which is related to the treatment. Okay. So treatment is always all in majority of times, there will be some things which will be related to the treatment. So you should be thinking about it. Okay. So this also leads to hypertrophy of tonsils and obstructive sleep apnea syndrome. Okay. Priapism because of just a second. Just priapism also because of this occlusion. Okay. Splenic infarction, gallstones, liver capsule pain. Okay. So there will be marrow hyperplasia as a result of anemia, avascular necrosis of hip. Okay. Dactylitis. This is I think because of some problems in the digits. Okay. So that's how you will be understanding what are the problems related to sickle cell disease. And it's very easy. If you think about it, then it will be easier for you to target. Okay. So there will be chances of infection because of repeated blood transfusion and immunosuppression. Okay. There will be marrow problems related to bone marrow. So you have to think about it. Okay. And you have to avoid the factors which can precipitate. So that will be the perioperative care. And in preoperative period, the things which will be important, it of course, as the name is telling, so you have to reduce the amount of the level of sickle cell hemoglobin S. Okay. So you have to try to reduce the level of hemoglobin S. Okay. So for that, there is one option of transfusing blood. This is one option. There may be exchange transfusion. This is one of the options. So according to the situation, but remember one thing, you don't need to overcorrect, because if you overcorrect and you increase the viscosity, the problem will be big. That is, when the blood viscosity increases, the flow will decrease. When the flow will be decreased, so already there are chances of occlusion. So you have to think about it. Okay. And these patients usually are compensated. Okay. So they can tolerate lower hemoglobin as compared to the normal individuals. So these things you should be considering. And for regarding the diagnostic test, the things will be related. Like, for example, if there is any organ involvement, there will be investigations will be related to that thing. Like, for example, there is ECG changes, there is ischemia, there is hypertrophy of heart chambers. So you might need, there are some signs of failure. So you can be doing some cardiovascular investigations. If there is some problem in the respiratory system, you may be doing ABGs, or you may be doing lung function tests and things like that. Okay. So similarly, the main diagnostic test, usually it is not the primary responsibility for you, but usually it is diagnostic, is either Sickle test or electrophoresis. Okay. So electrophoresis will be telling the exact architecture of the hemoglobin. So that is the more important thing. But Sickle test can label, because there are some areas in the world in which sickle cell disease is more common than in other part of the world. Okay. So in the patient in the areas when there there is more tendency, so whenever you are finding any anemic patient, they have to rule sickle cell disease. So they do it as like screening. Okay. So diagnostic tests are these, and then rest of the things, investigations will be according to the scenario and according to the presentation that patient has. Okay. So that is the chunk of the topic I have told you, and then we will just see the source from where we can. Of course, we have to treat the anemia. We can give. Can anyone tell what is the role of hydroxyurea? Because I have just forgotten. I couldn't recall it. Anyone who knows what is the role of hydroxyurea? Otherwise, I will need to check it out. If anyone can tell me what is the role of hydroxyurea in the treatment of sickle cell disease? Okay. So we will just try to, we will just come back to it. I will just try to search it out, or if anyone of you can tell, otherwise, because I cannot recall what is the role of hydroxyurea. Okay. And these are the things which I told you already, that sickle cell trait will be mild effect, and this patient can tolerate more hypoxia as compared to sickle cell disease. Okay. And there is another variant in which this is called as hemoglobin C, sickle cell hemoglobin C. Okay, this is also one of the variant of sickle cell disease. Okay, so as it is mentioned here, hemoglobin SS, hemoglobin AS, hemoglobin SC, and other. There are other hemoglobinopathies, alpha, beta, alpha thalassemia, beta thalassemia. We will just discuss them later. Okay. So these are the things. How would you manage anesthesia for C-section? So cesarean section, if someone is asking you this question, you will be saying that there will be physiological, pharmacological, and anatomical consideration because of a pregnant patient. Don't forget, because sometimes we forget this thing, that there is a patient who is pregnant. We are only concentrating on sickle cell disease, and when we are forgetting what are the changes which are related to the pregnancy, like any other patient. Okay. So that things will be exaggerated. The effects will be exaggerated. The result, you can say that it will be not 1 + 1 is equal to 2. It may be 1 + 1 is equal to 3. Okay. So that is what is happening. Okay. So they are isolatedly telling that why you will be transfusing blood, but actually the problems will be that there will be more chances of, because there is already hyperdynamic circulation in these patients, maybe because of compensation. If the anemia is severe and now pregnancy is again doing some further stress, so the patient may be this one decompensate. Okay. And as I told you that you should not try to overcorrect it. And actually hemoglobin level, more than hemoglobin level, is what is important is the hemoglobin S level. Okay. So we will just shortly see what is the acceptable hemoglobin S. I think it should be less than 40. I forgot the exact number, that how much it should be, but I think it should be less than 50 or something. I will just reconfirm it. Okay. So in the general principles are that you will be maintaining the PO2 level, you will be maintaining crystalloids, transfusion to maintain oxygen carrying capacity, and you will be, because there will be chances of embolism. Okay, so you may need to give venous stasis, and you should need to give anticoagulants on thromboprophylaxis. Okay, and you have to maintain the normothermia. Avoidance of the precipitants of sickle cell crisis, difficult IV access because of repeated blood transfusion, and there are more chances. And yes, this is what I was about to tell you, that because of painful crisis, these patients are on chronic use of opioids. So they are sometimes, because before coming to Saudi Arabia, I had never seen in Pakistan sickle cell disease patient. Okay. In Saudi Arabia, it's very common. And actually, they sometimes are in severe, terrible pain, and they are opioid tolerant. Okay. So they create a big problem. So even they are not responding to even strongest of opioids. So it is one of the most important challenges, that if the patients are on opioids, chronic opioid use, you have to do the considerations will be related to the opioids patients are taking, and you have to replace the baseline which they are taking, and then extra requirement will be according to the surgery. So you have to calculate, if the patient is taking oral opioids, for example, you have to convert, you should be knowing the conversion of oral to IV. And if you need to change the opioids, you need to see the equipotency. Okay, that how potent, like for example, how much potency difference between morphine and fentanyl. So fentanyl is 100 times more potent. You are giving 1 milligram of morphine, so you are giving around 100 mics of fentanyl, if I'm not wrong. Okay. So this is one of them. So as I told you, anemia and high output failure. This infections also because of involvement of spleen. Okay, psychiatric problems I just told you because of pain and severe, like it's a big depressive disease. And then intraoperative process, thromboembolic phenomena, and acute chest syndrome is the involvement of because of pulmonary infarcts, and it results in failure of respiratory system with PO2, low PO2, hypoxia, cough, and there may be hemoptysis, things like that. Okay. Renal impairment because of renal infarcts, pulmonary hypertension because of pulmonary infarcts. Okay. And you have to avoid dehydration, hypoxia, cold, alcohol, stress. These are the things, vascular stresses. Okay. So surgical acute pleuritic chest pain. That may be because of the differential diagnosis will be because of pulmonary embolism, acute chest syndrome, pneumonia, and pneumothorax. And you have to rule out according to the sign symptoms, and you will just further investigate. Okay. Sickle cell crisis, if they are there, they have to good analgesia, fluid replacement, avoidance of hypoxia. Okay. As I told you, this aplastic depression of erythropoiesis secondary to infection or folate deficiency in pregnancy. This will be because this case is because related to pregnancy. So they are telling because already there is increased requirement of this hemoglobin because of the things related to pregnancy, and there is physiological dilution of related to the increase in blood volume, disproportionate increase in plasma as compared to RBC. Okay. So these are the basic common thing which maybe, as I told you, that these patients are having difficult pain control, dehydration you have to avoid, and it will because it will be increasing the hematocrit and increase sickling. Okay. So exchange transfusion, as I told you, steroids, in some cases, steroids may be of some use. I don't know. Again, this is also, I think, related to immunosuppression or some things like that. Okay. I'm not sure. I'm not sure what is the role of steroids in sickle cell disease. Okay. So acute chest syndrome, as I told you, exact cause is known that because related to infarct. Okay. And there is fever, cough, chest X-ray changes, and maybe needing oxygen, CPAP, or then leading to IPPV. Okay. They have just told you the cyclic mechanism. Hemoglobin S tetramer undergoes a conformation change in the deoxygenated state and leaves hydrophobic residues, valine instead of glutamate exposed. These react with other globulin chains, forming an insoluble polymer. Hemoglobin S begins to aggregate at a PO2 of less than 50. The process is also time dependent. When exposed to oxygen, this I don't think so. This is too much important, but you should be knowing that there is the sickle cell hemoglobin S because of change of the alignment of the amino acid. This hemoglobin has some conformational changes, making it not as efficient as the other adult hemoglobin to face the hypoxia. That is the basic theory. Okay. Okay. So cause leukocytes to produce, and because of infection, interleukin 6 upregulate cell adherent molecules on the vascular endothelium. Like whenever there is an infection, there is a release of these interleukins. They are saying that upregulated, it is causing more stickiness. And vascular dysfunction. So activation of hemostatic mechanism, platelets and sickle reticulocytes bind easily to these cell adhesion molecules, cause clot formation and vascular. These are if they want to give you something extra, but the bottom line you should be knowing. Okay. We have discussed almost the most important thing, this chronic management, infections. To treat the infections, they are taking the influenza vaccine as well. And this is because some patients might underwent this splenectomy. And some patients might need, especially in children, they are if they are presenting for cholecystectomy. Okay, we have discussed about diagnosis and acute complications. Just a second. Anesthetic consideration. Let me show you the table. These are the procedures which they have, and they undergo cholecystectomy, as I told you, because of hypertrophy of lymphoid tissues causing obstructive symptoms. So it will be resulting in OSA in pediatric patients. Okay, splenectomy because of excessive hypersplenism, they have to do it. Umbilical hernia repair, as in non like it may be like any other common procedures which may be occurring. So this is something. Okay. Actually, the main normal till will be neutropenia. You see in hydroxyurea, maybe we will find it here. What is the reason of using hydroxyurea? Because it's just slip out of my mind that what is the role of hydroxyurea in patients with sickle cell disease.
The hydroxyurea increases the level of hemoglobin, fetal hemoglobin, hemoglobin F, and it reduces
Which is
sickling.
resistant, am I right?
Yes.
Okay, thank you. Okay, any questions? Because we have almost covered the main important points about sickle cell disease. Okay, so they are at high risk of osteomyelitis, bone infection. Again, remember infection, occlusion. If you remember these things, you will not you see dactylitis, painful swelling of small bones of hands and feet, as I was telling you, digits. Okay, and acute abdomen, it's one of the DD especially in pediatric patients. Okay, priapism because of infarction in avascular necrosis of bone. Okay, especially femoral head. Okay, so as I told you, hip avascular necrosis of neck of femur. Okay, long-term complications, as I told you, gallstones, sickle retinopathy. Yes, I forgot about retina. Okay, chronic renal failure due to renal parenchymal scarring. Okay, so things like that. So I hope you understand something. Okay. So because there are something concerns related to exchange transfusion, and what specialty would you like to refer to this patient? Like what will be the because remember one thing, when they are asking this question in the oral exam, Zishan, just have few words. What should be the preoperative hemoglobin S levels? The target preoperative
less than 30%.
less than 30%. This is one thing. This is one thing. What else? And another thing is that
Total.
I'm sorry.
Yes, sir.
Yeah, what will be the indications of exchange transfusion? It will be like that. If the hemoglobin S levels are more, they can give some blood transfusion to raise the normal hemoglobin level, or they will do exchange transfusion. Am I right?
Yes, sir.
Okay. So again, the same things: oxygen, dehydration, acidosis, temperature management, vascular system. What will be the role of tourniquet? Tourniquet is actually, you in the oral exam, if they ask, you say that you have to try to avoid them and you have to do the risk versus benefits. Okay.
Yes, sir. Right. You were just
So,
mentioning that which specialty should be this patient be referred to.
yes.
So I think pediatrics and hematologist. This patient should be referred to hematologist and pediatrics.
Yes. Like if it is in the pediatric, like remember, I just was about to tell you that in one of the exam, I failed because that patient was von Willebrand disease, and I did not mention that that patient should be optimized by a hematologist. So remember one thing: always try to not to forget discussion with the surgeon, discussion and think about any any subspecialty, you can refer the patient. Okay. So, okay. So I think post-operatively, this patient may be observed in HDU if there is any like risk of fusion or anything. Okay, so we will just finish here, and tomorrow we will continue with some other. Maybe tomorrow I will discuss thalassemia and porphyria. Okay. Thank you very much. Yes, Rifa, hydroxyurea increases cyclic GMP by interaction with transcription factors. I did not see this this causes induction of hemoglobin F synthesis. Also increases metabolism of nitric oxide, which further increases cyclic GMP. Okay, thank you, everybody. Thanks for your presence. Bye-bye.